Welcome to tonight's Immunisation Coalition webinar event. Our topic this evening is influenza in Australia. I'm Andrew Baird and I'm your presenter for this evening. I'm a GP in Melbourne and a member of the Immunisation Coalition. I would like to acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and the waters of Australia. Tonight, I'll be presenting for around 40 minutes. This should leave us plenty of time for any questions or comments. Tonight's presentation will be recorded, so all participants will automatically be on mute for the event. Please ensure that you fill out the evaluation form when the webinar ends to receive the certificate of attendance and the points if available. So now we're going to look at influenza, the disease. I mean, that's the prime focus for this evening. The reason why we're interested in influenza, the disease, is because 2022 is going to be a challenge. And we're going to be discussing this evening why that is the case and how we can respond to that challenge. So what is influenza? We all know it's a respiratory disease. It's caused by the influenza virus. There's a wide spectrum of illness, from asymptomatic to the precipitation of major events such as stroke and myocardial infarction. Interestingly, about 50% of influenza virus infections may be asymptomatic, due in part to pre-existing and partial immunity. Asymptomatic people do, however, shed the virus and therefore transmit the disease, but at a lower rate than the symptomatic individual. Let's have a look at the viruses. So during infection, the virus enters the epithelial cells of the respiratory tract and it replicates, producing more virus, which then enters other cells in the respiratory tract. The influenza viruses have two surface glycoprotein antigens, so-called hemagglutinin, which binds to the surface of target host cells so that viral RNA can enter the cells, and neuraminidase, which has three functions. It removes receptors from newly formed virus, allowing them to be released from host cells. Secondly, it destroys inhibitors to the virus in the mucus secretions in the respiratory tract, and this enables the virus to more easily infect cells. And thirdly, there may be other functions too, which have not yet been defined. I'm going to talk about antigenic shift and drift, and I've got a question for you. So have a look through the options and have a think about what the answer is. Disclose that the winning answer is actually D. So it's an abrupt major change in an A virus, resulting in new hemagglutinin or new hemagglutinin and neuraminidase proteins. So it's a big deal. So let's just look at a little bit more of that in detail. So what's happening? Influenza A and B are undergoing frequent changes in their surface antigens, their hemagglutinin and their neuraminidase. And we know that antibody against these surface antigens, particularly against hemagglutinin, reduces infection and severe illness due to influenza. So the changes are stepwise mutations of genetic coding for both of the surface antigens. If we get a quantum leap, and this might be where there's been a crossover between species from poultry, birds, from swine, then we will get a new strain or reassortment of strains, and that's called antigen shift, and that's a quantum leap. And it relates to the pandemics that have occurred in the last century. The Spanish influenza of 1918, which was H1N1, the pandemic of 57, which was H2N2, the pandemic of 68, which was H3N2, and most recently, the swine flu pandemic of 2009, which was H1N1. So those are shifts. But what's happening more insidiously in the background is drift. So that's more minor changes, but changes which are sufficient to evade immunity and to evade vaccines, which is why we have the composition of the influenza vaccine being updated and being reviewed annually. So talk a bit now about the illness itself. How does it spread, and what are the symptoms? Having lived through 2 years of the COVID-19 pandemic, we're all familiar with how respiratory illnesses spread. So aerosol, droplets, and direct contact with surfaces. The typical course of an influenza illness, reminding us again that there is a great diversity in the presentation of influenza and the severity of influenza, but typically an incubation period of 1 to 3 days, and then abrupt onset of respiratory symptoms and systemic symptoms as well. What about some of the complications of influenza? So for the majority of people, influenza will be a mild illness, but for a significant minority, there will be complications which can be severe. So there are respiratory complications, bronchitis, ear infections, and pneumonia, and particularly secondary bacterial pneumonia. That's more common than a primary influenza pneumonia. The risk of cardiovascular complications and cerebrovascular disease and stroke, encephalopathy, and some very rare complications such as Rey syndrome and Guillain-Barré syndrome. In fact, Guillain-Barré is thought to occur in about maybe just less than 1 in 100,000 episodes of influenza. And it's worth thinking about that because there have been concerns about the influenza vaccine causing Guillain-Barré syndrome, and the association of Guillain-Barré with influenza vaccine is about 1 in 1 million. So an order of magnitude less than Guillain-Barré due to influenza itself. What about the burden of disease with influenza? There's a significant morbidity and social and economic adversities due to influenza. So in a typical year, and we haven't had typical years for 2020 and 2021, but in typical years, about 5 to 20% of people will develop influenza, and it's higher in kids. So influenza-like illness, so influenza as defined, but also similar symptoms, accounts for significant morbidity in the community, economic losses, and a use of healthcare. So again, a typical year, so that's not been the last 2 years, but in a typical year, 1.5 million days lost at work, more than 250,000 GP visits, hospitalizations, and up to 3,000 deaths, per annum in a typical year. So a very significant disease. The big questions, what will those figures look like for 2022? And we don't know, except we're scared. We're scared because we know that there's reduced background immunity because there were reduced infections in 2020 and 2021, and more immune naivety. And also there have been changes in behavior. So whereas in 2020 and 2021, we had lockdowns and stay at home, and we practiced physical distancing and we washed our hands, we've sort of let a lot of that go. So the scene is set for the scene is set for influenza to walk on the stage and to play its part. So, and that is why it's important for us as healthcare providers to be thinking very much around prevention and to be thinking around the physical ways of preventing influenza, but also around very much immunization as well. So I've got another question for you. And I think Susie will come up with the poll for us. So international studies reveal that healthcare settings have some of the highest rates of presenteeism. So thinking about healthcare workers in Australia, what do you how many admit to going to work when they've got an influenza-like illness? So, well, the answer is C. It is about sort of 60%, but just to make you even more worried about that, if we look at healthcare workers experiencing just minor cold symptoms, so not the sort of the flu syndrome, then that number jumps to 99.2%. So in other words, most workers will go to work even if they've got respiratory symptoms. So, so we're talking about behaviors to reduce the risks of getting influenza, and that would seem to be a good target to be looking at sickness presenteeism, so that we should be thinking about protecting others by not attending work when we are sick. So behavior change required. So let's have a look at the increased risk of complications from influenza. So this is underreporting. This is from the National Notifiable Diseases Surveillance System. So again, not surprisingly, through notifiable systems, but it's probably underreporting. But we can see that this shows what's happened in the last 3 years. 2019, there were 905 influenza-associated deaths. That dropped to 37 in 2020, and last year there were 0 deaths reported. So something has happened, and that something was our behavior change in relation to SARS-CoV-2. And as a side effect of that, we reduced the transmission of influenza virus as well. So who is at increased risk of these complications from influenza infection? Well, older people and all Aboriginal and Torres Strait Islander people. There are others who are at increased risk: pregnant women, people with cardiac disease, people with chronic respiratory diseases, COPD, asthma, and the suppurative lung diseases such as bronchiectasis and cystic fibrosis. And many other chronic illnesses. People with other chronic illnesses are at increased risk of the complications from influenza infection, notably diabetes, renal failure, harmful use of alcohol. And there are more. So neurological conditions that will affect respiratory function. So we'd be thinking there of motor neuron disease, Parkinson's disease, stroke, spinal cord injury, chronic liver disease, people with impaired immune function due to malignancy or due to HIV. Preterm infants are at increased risk of the complications of influenza. Children taking aspirin are at increased risk. People with Down syndrome and obesity. So there are a multitude of factors which increase risk, and there are more. So essentially, everyone. So everyone over 5 and older, and whether they've got chronic disease or not, are at increased risk of complications. People who are in residential aged care facilities, but also in other institutional settings, prisons, for example, are at increased risk from influenza. People who are homeless And it's interesting that in South Australia, I don't know how many South Australians are here this evening, but in South Australia, vaccination is funded for influenza vaccine for homeless people. People who work in risk settings, poultry and pork industries, and central services personnel, so police, ambulance, medical and nursing, healthcare workers as well. So I'm going to talk a little bit more detail about influenza infection and these diseases, and we're going to start with cardiac disease. Interestingly, influenza is associated with increased pro-inflammatory, pro-thrombotic cytokines. So those are factors which affect cells, associated also with endothelial dysfunction, increased plasma viscosity, and increased heart rate. There is evidence that influenza infection is associated with the development of atherosclerosis and its complications. So during the flu season, we see increased rates of myocardial infarction and coronary death. We see increased incidence of acute pulmonary edema, of acute heart failure, and also secondary respiratory infections such as pneumonia associated with those as well. So let's look at respiratory diseases, firstly looking at COPD. So most of the morbidity and mortality associated with COPD is due to acute exacerbations, and viral infections of the respiratory tract play a key role here. And there is strong evidence that viral respiratory infections, particularly those caused by the influenza virus, increase the incidence of secondary bacterial infection, including pneumonia, in people with COPD. So influenza infection is an important cause of the excess mortality and morbidity in COPD. So that leads us to the conclusion that we need to be focusing on prevention of these infections in people with COPD. Let's have a look at asthma. Infection with the flu virus can exacerbate inflammation in the airways and in the lungs in asthma. Someone is not more likely to get the flu because they have asthma, but they are more likely to experience complications such as bronchitis and pneumonia, and therefore to require hospitalization. It's interesting, all people with asthma are at a high risk of serious health problems from the flu. However, the National Immunization Program only funds influenza vaccine for people with serious or severe asthma, but it really affects everyone. So influenza has been shown to cause severe exacerbations of wheezing, and about 1 in 10 episodes of viral wheeze are attributable to influenza, 1 in 10. The suppurative lung diseases, such as bronchiectasis and cystic fibrosis, developing influenza can exacerbate these conditions, lead to further complications and deterioration in lung function. Let's have a look at influenza infection and diabetes. Diabetes puts a person at a greater risk of any kind of infection. People with diabetes are at high risk of serious flu complications. They're at high risk of hospitalization and death. Acute illnesses can make it harder to control the blood sugar, and that can have consequences. Indeed, it can adversely impact the severity of the influenza virus infection. So with diabetes, a person with diabetes may develop more severe disease. They're at increased risk of lower respiratory tract infections, including influenza, but also secondary bacterial infections. Let's just put this in context for diabetes. So about 10% of deaths that are associated with influenza and pneumonia are attributable to diabetes. If we look at the general population between the ages of 25 and 64, people with diabetes are 4 times more likely to die with pneumonia and influenza compared to those who do not have diabetes, 4 times. Going to have a look now at one of the other risks of complications, and that's for pregnant women. So pregnant women planning pregnancy are at increased risk of morbidity and mortality from influenza. And this is thought to be due to a selective suppression of immune components which relate to influenza. So that influenza can become more established and is more likely to cause complications. The risks of complications in pregnancy increase as the pregnancy progresses. The College of Obstetricians and Gynecologists recommends annual, it doesn't recommend annual, it recommends vaccination in every pregnancy. So that may be more than annual, that may be 2 a year. And it's important for us to recognize that vaccination of mother also protects the neonate, protects the baby. Vaccination with influenza vaccine at least 2 weeks before birth not only protects the mother, but it also protects the baby. And that's important because infants less than 6 months who get influenza have the highest rates of hospitalization and death of all children. So everything we can do to protect infants under the age of 6 months, the better. And another group of people, and we're seeing more of these now, and that's travelers. So not many of them in 2020 and 2021, but now, as it says on the boat, Anthem of the Seas, and we are singing the song, we're all back in travel. So the seas are once again open to travel, and as is airline travel. So flu is a frequent vaccine preventable illness in travelers. In the tropics, it's all year round. There are seasonal peaks in the northern and the southern hemisphere. And a lot of people travel. Almost half the Australian population undertakes international travel. And the risk factors are the boats, the planes, the airports, and the mass gatherings. So we should be thinking about influenza vaccination for travelers, and we certainly should be recommending it for travelers too. What about the NHMRC recommendations for influenza vaccination? So we're going to move on now to vaccination. And the recommendation is that annual vaccination for any person aged 6 months or older. A strong recommendation for immunization with influenza vaccine in groups who are at risk of severe influenza or the complications thereof. And advice that we as healthcare workers should be actively promoting influenza vaccination to these groups, so to everyone over the age of 6 months, and to those who are in the risks, in the groups at risk of severe disease and complications. That's enough from me for a little while. We've got another poll for you. So this is a question about receiving 2 doses of in the same year. So have a look at that and see what you think. The correct answer is in fact D. So thank you, well done. So all of the, A, B, and C are eligible for the 2 doses of influenza vaccine in the 1 year. So certainly for children who are getting flu vaccine for the first time, children under the age of 9, if that is recommended. If they miss it 1 year, then they don't need to have it 2 doses in the next year. That just means they've missed it in that first year, and that happens. Individuals who've had hematopoietic stem cell transplant or solid organ transplants are immunocompromised, immunosuppressed, And it's really a way of giving them a bit of a boost to their immunity against influenza in order to reduce their risk of lower respiratory tract infections and from pneumonia. And as we said earlier, a woman should be vaccinated against influenza in every pregnancy. So a woman might have been vaccinated for the seasonal flu earlier in the year, and she then becomes pregnant later in the year, so she will get a second dose when she's pregnant. So the C is correct as well. So thank you, everyone. So we're now going to look a bit at government funding of the influenza vaccine for the at-risk groups. So the National Immunisation Programme, the NIP, provides free influenza vaccine for people who are at risk of severe influenza by age. So that's people 65 and over, children 6 months and less than 5 years, all Aboriginal and Torres Strait Islanders from the age of 6 months, and children 6 months to 10 who are on long-term aspirin therapy. There are also free vaccines for people in at-risk groups, and we've looked at a lot of those at-risk groups already. So that includes people with cardiac diseases, respiratory disorders, neurological disorders, metabolic disorders, including diabetes, impaired immunity for various reasons, and malignancies, and not forgetting women. So pregnant women are eligible for a free flu vaccine as well. So when should the influenza vaccine be administered? And probably the answer is about now. So what we need to be thinking about, the peak months for influenza are late autumn to early spring, so sort of May to September. At least that's based on 2019. We haven't got much to go on for 2020 and 2021. But we should aim to allow time for immunity to develop, so 10 to 14 days. Residents of Northern Australia and pregnant women should get it as soon as it becomes available. The duration of immunity or protection for older people is probably shorter, and perhaps only 3 to 6 months. So we want to avoid giving it too early to them, because we don't want them to be running out of protection before the season is coming to a close. So, but vaccinating older people from April would still be appropriate, so as of now. Some people will miss the pre-season window, like now. That's okay. The vaccine should be given whenever. And how often to vaccinate? Well, every year. As we've just talked already, with both antigenic shift and with antigenic drift, the virus is always changing. So it is always eluding the vaccine. So we need a different vaccine. And also the antibody levels from vaccination will dwindle over time. So we need to boost the antibody levels. So for the reason that the antigens change and for the reason that our antibody levels decrease, the recommendation is to boost and have a vaccine annually. And even if the vaccine is the same, even if the vaccine hasn't changed from the previous year, the recommendation is still to boost with an annual vaccine. What about adverse effects from the influenza vaccine? Yes, adverse effects occur. The local reactions are at the site of the injection are very common. Systemic effects are common, fever, myalgia, malaise, headache, and allergy reactions are rare, such as hives or angioedema or anaphylaxis. There are contraindications to the influenza vaccine. That's where there's been anaphylaxis to any previous influenza vaccine or to any component of the influenza vaccine. Interestingly, although most influenza vaccines are made on egg, egg is not a contraindication egg allergy is not a contraindication to having the vaccine. So the Australian Immunisation Handbook tells us that people with egg allergy, including anaphylaxis, can be safely vaccinated with influenza vaccines. If there is significant health professional anxiety, and there may be, or significant patient anxiety or parental anxiety, the vaccine may still be administered in a primary care setting, but with a longer waiting period, say of 30 minutes. The Australian Influenza Vaccine Committee has defined the composition of the influenza vaccine for Australia for 2022. And the good news is we don't need to remember this. What we do need to recognize that this has changed from 2021. So Hong Kong has become Darwin, and Washington has become Austria. The other components are the same. So this is for the egg-based flu vaccines. Australia now has a cell-based flu vaccine, and it has a different composition. So in fact, there's just one element that's different, but it is a different composition. We could spend some time talking about the cell-based flu vaccines. Growing influenza viruses in eggs may introduce changes called egg adaptation, which can cause differences between the viruses in the vaccine and the selected strains. So there may be some changes, and those are avoided by using a cell-based flu vaccine. Going to look at influenza vaccines for children. So the vaccines available for children under the National Immunisation Programme this year, Vaxigrip Tetra, Fluarix Tetra, and Afluria Quad for children 5 and older. There are other vaccines that are registered and available for children, but they are not funded under the National Immunisation Programme. So there's plenty of choice. So we've looked at children. What about the influenza vaccines for older people? So there are 2 adjuvant or enhanced influenza vaccines available for older adults this year, Fluad Quad and Fluzone High Dose Quad. So for people aged 65 and over, Fluad Quad is preferred over the standard influenza vaccines. The standard influenza vaccines can still be given, but the Fluad Quad is preferred because it is likely to give a better immune response in an older person. There's no preference between the Fluad Quad and the Fluzone High Dose Quad. I'm going to show you a chart. And it's okay, I'll talk you through it. This is data for last year. It's notifications of laboratory confirmed influenza by age group. So on the horizontal axis, we've got age groups, 5-year age groups. And on the vertical axis, we've got the incidence, the rate per 100,000 of the population. And all you have to look at is the blue line at the top of the chart and the red bars. The blue line is all influenza infections in 2021. The red bars are influenza A. And both of those show that there are 2 peaks. There are 2 peaks, and one peak is in young children and the other peak is in the elderly. So those are the age groups that are affected by influenza, with the proviso that this is 2021, which was an atypical influenza year. What do you think that chart will look like for 2022? Going to have a look now at really a chart which shows us all of the seasonal influenza vaccines registered and available for use in Australia in 2022. So the first column shows the age group, and then we've got columns for each of the 8 vaccines that are available, that are registered for use in Australia. And the ones that are multi-purpose seem to be VaxiGrip Tetra and Fluorix Tetra, so they apply at all ages, and they've also got National Immunisation Programme coverage, so they're free for most people as well. It's worth mentioning that Flucelvax, which can be used from the age of 2, is not on the National Immunisation Programme, so it hasn't got a white box, and the current costs are around about sort of $40 to $50 for Flucelvax, whereas the egg-based influenza vaccines, if they're being purchased privately, are nearer $10 to $20. So the Flucelvax costs a lot of money. Why have it? Well, that might be, we're probably running out of time. We won't be able to talk about that too much, but it's thought that it possibly gives better immunity to the influenza virus. And data. So it's important that we collect data. The Australian Immunisation Register helps us with this. So unfortunately, I haven't noted what year this is for, but 3/4 of the older people and 1/4 of younger people. Is that good enough? It's certainly nowhere near what we're doing with SARS-CoV-2 vaccination. Talking of SARS-CoV-2, so similar symptoms, at-risk groups are similar. Most people experience a mild disease. Vaccination against influenza will not protect against COVID-19. It's important to be vaccinated against influenza. If someone develops an infection from influenza and then develops COVID-19, the effects could be catastrophic, and vice versa. And important that whereas last year we were told to not to co-administer influenza vaccine and SARS and COVID vaccines, now we can. So patients can have them at the same encounter. Going to shout out for practice nurses, and I'm sure there'll be some practice nurses in our audience tonight. In fact, I take challenge with the title. The title is The Practice Nurse as an Advocate for Adult Immunisation, but I would say the practice nurse as an advocate for all immunisation. So practice nurses, accessible, respected, able to provide education and information, and general practice is at the forefront of healthcare in Australia. And that's, I have to say that with respect, because I know that there are other healthcare providers in the audience tonight, and that's not intended to be disrespectful to non-general practice and to pharmacists and to nurse practitioners. So we all have a role to play. So we've almost there. So what about some conclusions from our discussions this evening? Many people are at increased risk of severe influenza or influenza-related complications. The recommendations are yearly influenza vaccination. Funding for vaccines for at-risk groups is available through the National Immunisation Programme. Free flu vaccines are available for children under the age of 5. Individuals who are at risk should be encouraged to speak to their doctor or healthcare worker, healthcare provider about influenza vaccination. Also, vaccination of those in close contact with at-risk individuals can provide those at risk with an additional level of protection. So if you're a relative of somebody who's at risk, by getting yourself protected, you might be protecting your at-risk relative. And here's a slogan: prevent influenza in 2022. So that's our challenge. That's what we need to do. A couple of other take-home messages. think about offering influenza vaccine to everyone aged 6 months or older, and think about pre-vaccination checklists to identify those at-risk individuals for whom immunization against influenza is not just desirable, it's somewhat imperative. Now, there may be some other topics that we could cover, we haven't had a chance to look at. So what about diagnosis and testing? What about periods of isolation and quarantine? It's not quite the same as COVID-19. The treatments that are used, indications for the treatments and how they work. A little bit more on the egg-based vaccines, talking a bit more about booster doses. We've mentioned that already in regard to the stem cell transplant, the solid organ transplant, the children under the age of 9 and pregnant women, but travelers as well, should they be getting a booster? Or what about older people? We said their immunity wears off, should they be getting a booster as well? We talked a bit about co-administration, and essentially the answer is yes. I didn't mention that there is potentially a caveat around using Shingrix and Fluzone, using two adjuvanted vaccines together. They can be given together, but it's probably preferable to separate the two. And what else do we do in the Immunisation Coalition? Well, we do art. So there's an art prize. We have a vaccination day, which is coming up shortly. And the Immunisation Coalition website has the NeumoSmart vaccination tool, which tells you, which helps to sort out some of the complexity around pneumococcal vaccine recommendations in children and in adults as well. So I think that's as far as we go with our presentation. So thank you very much for your patience and for listening. And I will now have a look at some of our questions and answers. Is that okay, Susie?
That sounds wonderful. You can keep the PowerPoint shared, or you can stop the share, whatever you'd prefer.
I'm happy with the screen there. So, so I've got a question from Gemma, and this is about presenteeism. In addition to asking healthcare workers to change their behavior, what else can be done to reduce presenteeism? What a fantastic question. And I wish I had the answer, because clearly it's a major problem and a problem of some magnitude. If we look at 60% going to work with flu and 99% going with a cold. Do you think we could have an incentive? Can we pay people money to not to turn up to work? Could we have a campaign, advertising campaign, to advise healthcare workers of the risks of turning up to work when they're sick? I haven't got. I don't know if there are any projects in place, but it'd be certainly worth our government's Department of Health looking at some strategies for helping to reduce presenteeism, as it's clearly a major impact on workforces, but also on the clients, the healthcare clients as well.
And Andrew, I know the Immunisation Coalition would be really interested in actually putting together a campaign to assist in this area. So if anyone attending has ideas, pop them in the chat box and we'll take a look at them afterwards and see what we can come up with too.
That's a great idea, Susie. I think, yeah, we're very solution focused and practical. So I think that's a really good idea. And it's a great question, and it'll make an enormous difference. Yeah. So question from Penny. Exactly how severe does asthma need to be to receive a government-funded flu vaccine? And yeah, there are formal definitions and criteria which are in the Australian Immunisation Handbook, and I would have to say off the top of my head, I can't quote them, but they relate to therapy, so taking an inhaled corticosteroid or other preventer medication, frequency of exacerbations, frequency of hospitalizations as well. So those are the criteria that are in that requirement. So, but if you have a look at it's under the influenza page in the Australian Immunisation Handbook. It does define it. So I'm sorry I can't give you a definite answer, but it is there. So I've got a question from Melissa. If Fluad Quad isn't available, should we wait until it is available, or just opportunistically give one of the standard vaccines, so Fluarix Tetra or Vaxigrip? Great question. I think the preference is to give Fluad Quad, but if you don't have it, it's better to be immunized against something. So I think the argument would be give something. So otherwise your patient is potentially going to be unimmune and vulnerable as the flu season develops. So you can make an argument one way or the other. You can always give the Fluad Quad later. When we talked about that, about being able to give a second dose. So you could always give the Fluad Quad as a booster. So at least the patient's got something on board to start off with. I suppose the other thing is to see if we can, there's always the flu zone that may be available. That's not available under the National Immunisation Programme, but for some patients that may be an option as well, so that they can have the adjuvanted vaccine, but they will have to pay more for it. So there's a question from Christian. Do you feel that there is a need for more rapid diagnosis of influenza and differentiation from COVID-19 in primary care settings? The answer has to be yes. I mean, that would be fantastic. We have people with undifferentiated respiratory symptoms, and we said in that third slide from the end that COVID-19 and influenza have very similar clinical presentations. So how do we distinguish between the two? So we want something where we can have a rapid test. So at the moment, the tests for influenza are PCR tests on either nasopharyngeal swabs or on throat swabs, but that hasn't got a rapid turnaround. I mean, that's going to be 24 to 48 hours turnaround. So we don't have anything that's equivalent to the rapid antigen tests that we have for SARS-CoV-2. So I think Christian's question is great, and absolutely agree. And again, that's something which we need to be looking into getting developed. Another good question from Angela. What is the interval between having COVID-19 disease and getting a flu vaccine? That's, again, I haven't answered that question before. I would probably defer to, again, looking at the resources. So I would be, we might put a note on the Immunisation Coalition website on that one, please, Susie. But my understanding is it would be as soon as you've recovered. So which is the same as the question is, when should you have your COVID-19 vaccine after COVID-19 disease? And the answer is as soon as you've recovered. So there's no benefit in delaying. So I believe my belief is that there'll be no benefit for delaying with the influenza vaccine, but I can't be certain. So before rather than quoting me on that, we'll get that answer.
Yeah, Andrew, it's actually a bit of a fluid situation and still changing because the evidence and data is still coming in. Sure. I would suggest at this stage, because it is changing regularly, that patients should be speaking to their GP about their particular risk level and what their own pre-existing problems, and get the advice from their GP at this stage. We will, however, put a PDF together and pop it on our influenza page for healthcare workers and try and clarify as much as we can.
That's it, thanks. Yeah, as I say, I can't give a definite answer to that. I've just got to, what's the word, conjecture. Question from Robin. Are there strategies to offer flu vaccine to pregnant women or pending overseas travellers in the months between the expiry date from the previous season's flu vaccine and availability of the new season's flu vaccines, often February and March of every year? That's interesting because the vaccines usually have an expiry date of January. So there's this period of February and March where there are no vaccines available. We're still waiting for the new season's vaccines, and the old season's vaccines have expired. I don't know, Robin. Susie, do you have an answer to that? Do you know of any strategies that, as you say, we want to give somebody a flu vaccine in February or March, and there aren't any flu vaccines?
No, I can't answer that one, but that one I will actually copy and send off to Angela and pop in the PDF, because I think it is important with the Northern Hemisphere strains that are coming out and the timing. So that's a great question. Thank you.
Yeah. Oh, and this is fantastic. Jane has told us that BD make a flu testing kit, which takes about 20 minutes for a result. So compatible with our RATs for SARS-CoV-2. And the GPs in Jane's clinic use it. So isn't that fantastic? So there we go, it exists. So BD make it. I wonder how much it costs. That's good. Good, and I think we've come to the end of our Q&A. So unless there's any last minute questions coming in.
Did you address the Fiona Wilson question? What is the time frame between flu and Zostavax?
No, I haven't seen that one. Missed that one.
So Fiona's asking, do you know what the time frame between flu and Zostavax vaccine is, please?
Good question. The answer, I don't know. That would be one to look up. I don't know. And I'm not sure about co-administering either. Don't know.
That's okay. We will pop all of those unanswered questions, if any, with clarifications in a PDF document on the website. This webinar has been recorded, so as soon as that recording is edited and available, probably within the next week or so, we'll have a supporting document with the PowerPoint presentation and a Q&A document as well. Thanks, Andrew.
Great, thank you. Look, thanks very much, everyone. Thank you so much for your attendance and your participation. Thank you for your questions. Wish you well, stay well, and everyone have a good evening. Thank you.